The next speaker, we go back a couple of months, and he's going to be speaking about relapse therapy and clinical trials. Dr. Abonour has been answering some questions here throughout the process, and I have great respect for him. And without further ado, I'd like to introduce Dr. Rafat Abonour, Indiana University School of Medicine. Take it away, Rafat.
Thank you, Callie. It's good to see you again virtually. Hopefully we'll see you soon. Today it's raining in Indianapolis, so I couldn't, really do anything more exciting. So it's good to be with you today. And what a nice introduction about multiple myeloma by Dr. Ganguly. Wonderful job. So I'm going to pick up the part where patients now start relapsing. And so the question, what do we do here? How do I treat patients with relapsed multiple myeloma? If you can give me the second slide, please. Next slide. So when should we treat patients with relapsed multiple myeloma? Should we treat them when they have biochemical relapse? What does that mean? Their myeloma proteins start rising. They went down to 0 or 0.2, and now it's 0.5 or 1. Should we treat then? Or when the involved light chains start rising, somebody who has a lambda light chain normalize, and now instead of being normal is 5-time upper limit of normal. Do we treat then? Or do we treat when we have clinical relapse? What does that mean? About the CRAB criteria you heard about for diagnosing myeloma. Patients start becoming anemic or had kidney failure, very high calcium, new bone disease, or patient who developing now what we call extramedullary disease or plasmacytoma, myeloma growing outside the bone. When do we treat? Next slide, please. We don't know. But we can speculate. Most approved treatment is basically, in relapsed multiple myeloma, any trial is really based on biochemical relapse. But there are some observations support better outcome when treating at biochemical relapse. For example, Mayo Clinic did a study that's showing if you treat at biochemical relapse, the time without progression is much higher than if you treat at time of clinical relapse. Patient on the median have 125 months versus 81 months. So maybe treating at biochemical relapse is a good thing. Next slide. But the problem is, 25% of biochemical relapse patients will have a smoldering course, like a smoldering myeloma, and they don't progress for 2 years. So we're treating, 4 patients, one of them may not need to be treated. So that's the con, I think. The pros is that when you start having your biochemical relapse in a relapse setting, refractory disease, actually the patient will start having symptoms in 5 to 6 months. So you don't want to have a patient with biochemical relapse, you're sitting on them, and then 6 months later, they have a broken vertebra in the back. That's not a good thing. And I always say that if you don't get it right at first relapse, you may not get it right at subsequent relapses. So next slide, please. So if you look at the duration of response with each relapse, if you look at first, second, third, fourth, fifth, sixth, the duration of response is shorter. Myeloma become more aggressive, harder to treat, and the patients will enjoy only a shorter duration of response. Next slide, please. So next, please. So I think, the things we need to remember about multiple myeloma is that each myeloma patient, especially with each relapse, they don't have the same kind of myeloma cells. They have a family of myeloma cells. We call that clonal heterogeneity, which means that each time you're treating myeloma, you're treating different kind of myeloma in each patient. So you have one part of the cell, some cells will respond to drug A, but not drug B. Other cells will respond to drug B, but not drug A. And so this wide heterogeneity within each patient really require a combination therapy. You cannot expect a relapse patient to benefit from one drug. We used to say, well, sequencing versus, treating them right. And I showed you, already that each relapse, the duration of response is less. So when you have a relapse patient and you say 30% of the patient respond to drug A, do I just want to use drug A and only 30% of the patient respond to it, I think combination therapy at relapse makes sense. Next. So basically, in English, clonal heterogeneity is that myeloma cells in each patient is like a family of odds and aggressive members. The longer this family sticks around, the odder and more aggressive they become. So family therapy is not going to work. You need to treat them early. You need combination therapy. Next, please. So factor that influence the choice at the time of relapse, disease-related, regimen-related, patient-related. So what are they? Next, please. So if you look at disease-related factor, how are they relapsing? Do they relapse with, broken bone, high calcium, renal failure? Do they have a new plasmacytoma? Do they have higher risk cytogenetics, extramedullary disease, plasma cell leukemia? All that stuff can influence, obviously, their choice. If you have a high-risk disease, plasma cell leukemia, makes sense to include a class of drug we call PI, proteasome inhibitor, Velcade, Kyprolis, and the like. Next, please. Then the regimen-related factor. What was the previous treatment and dose, duration of response to it, the side effect to it, and the depth and duration of previous transplant? So if you have somebody who transplanted in 2006 and have done very well, and now they're relapsing, in 2021, that's a good response to transplant. I would consider it again. If they had a regimen, they had no side effect to it, and now they relapse 5 years later, I may consider the same regimen if, they don't have any side effect. If you have neuropathy, you want to avoid drug that cause neuropathy. If you have heart failure, you avoid drug that cause heart failure. So the regimen-related factor, I think, is very important. Next. And patient-related factor. I mean, obviously, we can't be very aggressive with patient who's not that strong. But if you have somebody who has a good performance status and had a transplant 15 years ago and doing well, we can do it again if they're in good shape. What else going on with the patient? Do they have diabetes? Do they have heart failure? Do they have neuropathy? That influences the regimen we choose. And obviously, transplant eligibility can be also a factor. And I think the last two things are very important. Patient preference. I mean, the patient said, listen, I actually don't have time to come to the clinic to get an infusion 2 days a week. I want a regimen that it's easier for me, an oral regimen and things like that. We should honor that. And I think there are combinations that can be that way. And obviously, we still enjoy in America that, we can give any drugs we want, but that may become a little difficult. Cost and socioeconomics may play a role in choosing the regimen for relapse patient. Next, please. So this is currently available anti-myeloma agents. So once you relapse, it's not a bad news, okay? Look at this. I mean, I think, Dr. Ganguly and, can attest to this. When we started doing myeloma therapy, we had melphalan prednisone. And then, we start having the transplant, and then we had the Revlimid, and, after thalidomide, and then we had the Velcade and 2 PIs after that. And then we have all these new drugs, the anti-CD38 drugs, the anti-CS1, the anti-BCMA, the CAR T cells, and then the selinexor. So a lot of options for the patients. We have a new alkylating agent, melphalan, and then don't ever forget venetoclax for patients who have translocation 11-14. They actually benefit from this drug, and they can be used in combination. So it's really a very good place to be today in myeloma therapy when you have, I don't know how many here, 14, 15 different options, drugs available that are FDA approved for myeloma. When we started doing myeloma treatment, we had 0 drug approved for multiple myeloma. Next, please. So how does your oncologist decide how to treat you for multiple myeloma? This is it's like you're going to what? Cheesecake Factory, and you're getting a menu that is about, encyclopedia of options. There's a lot of options. So they don't look at this kind of menu. Next slide. They look at what we call the NCCN guideline. So that's the National Comprehensive Cancer Network. And this is a group of myeloma experts from these centers sit down and say, okay, this regimen is great. Let's use it. RVD, we use it for every patient. And then we call that, category 1. If you really don't like the regimen, you think the data is not that strong, you make it category 2. Well, these are category 1, most of these patients. If you look at, those regimen, look how many options available to them patient. It's great news that we have options. The bad news is that how your doctor may get confused, So I think studying the patient, studying the genetic of the disease, the presentation of the disease will help you choose one of these options. Next, please. So if you look at easier sort of guideline is our colleagues at Mayo Clinic comes up with these called the MSMART, first relapse off study. What do you do? If somebody was on maintenance Revlimid, they recommend you try a different image. So for example, if somebody has relapse with, and fit, you can consider Kyprolis or carfilzomib with Pomalyst or pomalidomide. Or you can consider daratumumab with Velcade. If somebody has an indolent relapse or frail patients, maybe you can consider an oral regimens like Ixazomib, Ninlaro with Revlimid, or something else. If you are off therapy and maintain and you relapse, you can do KRD is a good regimen, or you can do daratumumab, Revlimid, dexamethasone. So this kind of approach try to sort of reduce the confusion that the NCCN guidelines provide. Next, please. And this is for second or later relapse. And you can see there's circulating some of the drugs that used initially, but it probably the highlight of these, regimen is that a monoclonal antibody and anti-CD38 is considered there. And obviously one will need to also consider BCMA antibodies eventually in the relapse setting. And we'll talk about that in a minute. Next, please. So combination is really better. I mean, so this is, the first trial in relapse setting that looked at Revlimid Dex because that's what people used, 15 years ago or 10 years ago. When you relapse, you get on Revlimid and dexamethasone. You get Revlimid 25 milligram daily for 21 days and Dex 40 milligram once a week. So the question was, can adding a monoclonal antibody, you saw the picture of how the antibody worked, this daratumumab in this case, can it work? So this is a clinical trials where half the patient get Dara Revlimid and the other half just get Revlimid. So the question is, what is the sort of duration of response, the overall survival and things like that? So next slide, please. So what they showed in this trial, next please, is that something we call progression-free survival, which is really time without needing to worry about myeloma or side effect related to myeloma. It improves significantly when you add daratumumab. At 30 months, there are 58% of the patients were without progression, and if you use Revlimid alone with Dex, it was 35%. So clearly a 56% reduction of the risk of progression by adding daratumumab. So that proved that 3-drug regimen with daratumumab in the relapse setting is very effective. Next, please. And they looked at, whether you actually use it, somebody who just relapsed quickly from last line of therapy or more than 12 months, and the benefit was the same. Because sometimes you say, if you relapse too quickly, you have a very bad myeloma. You may not have the same benefit from new treatment. And the answer is actually no, you still get benefit. Look at the patient who relapsed in the first year after their initial treatment. 70% stayed without progression if they get daratumumab versus with Revlimid versus Revlimid alone. So I think for any relapse, a monoclonal antibody with an IMiD is a very good thing. Next, please. And obviously now we have another monoclonal antibody, Isotoxumab, and that has been, this drug has also been tested with an IMiD, pomalidomide in this setting, and also been tested with carfilzomib, Kyprolis, and it clearly showed that adding the monoclonal antibody to IMiDs, POM, adding the monoclonal antibody to Kyprolis, the K, is superior in terms of progression-free survival, and that's what led to FDA approval of these combinations. Next, please. So, anti-myeloma antibodies are interesting and evolving. So antibodies like daratumumab and Isotoxumab are the naked antibody. They just bind to the myeloma cells and then bring the immune system, the complement and the cytotoxic lymphocyte to help eradicate the myeloma. But nowadays, I think people are trying to be more fancy. Can we make an antibody more powerful by adding to it what we call a conjugate, such as in BCMA, methylprednisolone. It's an alkylating agent. It's a chemotherapy. Once this antibody binds to the myeloma cells, this toxin goes inside the myeloma cells and blow it up. And then we have these called T-cell bispecific antibody. So when we give the naked antibody, we ask the immune system of the patient to work. And sometimes it's kind of lazy, the antibody binding to the myeloma and the immune cells go by and it just doesn't care. Well, can you make that antibody more specific? So one part will bind to the myeloma and the other part will bind to the immune cells of the patient. So when the immune cells go by and get attracted to that receptor, the T-cell antigen. And so these are the bispecific antibody, and there's like 5, 6 of them, and it's just amazing how well they're working. And then obviously, you get the CAR T cells that are amazing too. So we'll talk about that in a second. Next slide, please. So these are sort of comparison of the CAR T cells, the bispecific antibody, and the antibody conjugate. So CAR T cells, you all heard about it, is basically what we do is we take your T cells, which are the immune cells. Their job is to fight viruses, to fight foreign cells. And what we take these T cells from you and we send them to a manufacturing facility where they make these T cells recognize myeloma and kill myeloma. So that's what we call it, chimeric antigen receptor T cells or CAR T cells. So it's amazing. We have several CAR T cells now. One of them already approved, the Abicma, and then probably one will be approved in next month, in November maybe. And basically what they do is, they go in and they kill the myeloma cells and they get patients free of myeloma, MRD negative. So that's great. However, most of the trials showing a progression-free survival of about 1 year. The science of CAR T cells is amazing. The response is amazing. What's not amazing is the duration of response. Why? Why is myeloma cells are still resistant and they a year later come back? You don't want to give somebody $450,000 drug that only worked for a year. So maybe we need to give another dose of CAR T cells or something else, or do some maintenance for a while after the transplant, or make all myeloma cells visible to the CAR T cells. Those strategies are being tested. We actually have, some clinical trials trying to start for that. So the problem with CAR T cells is that, you have to have the T cells, you have to manufacture them, you have to keep the disease under control until the CAR T cells are available. And the last problem is the duration of response. On the other hand, the bispecific antibodies off the shelf, you can order it from the pharmacy. It's going to be used, and we don't have anyone approved yet, but I expect one will be approved in the first quarter of next year. Those are great because, you don't have to worry about manufacturing. You don't have to worry about bridging therapy while you're waiting for the CAR T cells to be ready. So you can give them right away, and they don't have the same degree of side effect of CAR T cells. CAR T cells have to be given by experienced physician at an experienced facility. because you can get something called cytokine release syndrome. You can get neurotoxicity that, you have to know how to manage it. If you don't know, the patient may not do well. So, but the incidence with bispecific is less. So advantage of bispecific, off the shelf, less toxicity. You can keep using it until you get your patient into a lasting MRD negative, so the patient do well. And then the antibody conjugate, again, is off the shelf, it's available. And we have one already approved, no CRS, no hospitalization, outpatient therapy. The ocular issues, we'll talk about it in a second. Next slide, please. So why BCMA? Why all the CAR T cells, the bispecific, the conjugated antibody, like the BCMA as a target? Is actually, it's not just being present on the surface of myeloma cells and the pre-myeloma cells, but also BCMA does control the proliferation of these cells, make them grow. So if you engage it, turn it off, these cells will die. So there's multiple mechanisms by which myeloma cells die when you use a BCMA antibody. So it's very attractive. Next, please. So the drug that's available and approved by the FDA, now we've been using it for a while, belantamab mafodotin. So basically, if you look at the box here, what you're seeing is that the antibody is binding to the myeloma cells. The mafodotin, which is the alkylating agents, goes inside the myeloma cells and blow it up. You use the immune system also to kill the myeloma cells. So really a lot of different players playing a role in sort of destroying the myeloma cells. So although it's a single agent drug, but it's really more than single agent drugs, probably couple drugs and also using the immune system. So next, please. So in the first phase 1 study called DREAM-1, and now we have actually up to DREAM-6 trial ongoing, looking at the drug in combination. In single agent and highly refractory patient, the response rate was about 60%. There are a lot of, what we call stringent complete remission and complete remission, i.e. very deep response in this setting. So it was very exciting to see such a depth of response with a BCMA conjugate antibody Blenrep. Next, please. The issue that continue to be a problematic is the ocular toxicity. So we don't really understand it completely, but the outer layer of your cornea get damaged. So you get what we call keratopathy. So the lining of the of your cornea maybe get damaged. So for that reason, this drug is only giving when you have an eye exam within 2 weeks of prior to each treatment. And obviously, if you have a significant toxicity, you have to hold the drug, adjust the drug. But there are a lot of clinical trials looking at dose modification to try to improve the outcome. For example, in one of the DREAM trial, looking at, instead of giving the drug every 3 weeks, they're looking at every 6 weeks. So that may answer the question of the ocular toxicity. It's not to be minimized, and hopefully we can overcome it because I think it's a very active drug. Next, please. So there's another trial looking at new alkylating agents called Horizon. The trial looked at this drug called melphalan in combination with pomalidomide, presented with Dr. Paul Richardson. Next, please. So this is interesting because it's a lipophilic kind of drug. It goes inside the myeloma cells. Because of this, the myeloma cells have this very high level of this enzyme. It can break it down, release the chemotherapeutic agent within the cells, and lead to the destruction of the myeloma cells. So next, please. So it looks like it's effective in about a third of the patients and in all the patients. And it worked in patients who have had all kind of treatment prior to that. So it's a very interesting drug. Obviously, you have to watch your CBC, your white cells, red blood cells, and platelet. It may be suppressed and adjust the treatment accordingly, but it's another option available to patient. Next, please. So I think this is my last slide. I mean, what is the best therapy for relapsed patient? I mean, the thing about it is that need to remember that not all relapses are the same. I mean, so you have a, biochemical indolent relapse, you have a symptomatic relapse. And I think we need to remember when patient relapse, they're relapsing with several clones of different characteristic. So I believe that combination therapy does provide better outcomes. And the good news is that, we have better drugs, we have more drugs available, we have better combinations. So I think is the, I always tell my patient that myeloma is not a death sentence. I mean, I think obviously I would love to say that we're going to cure you. And I think some of the early trials with 4-drug regimen hopefully will cure a large number of patients. Some of the drug we're using, for example, CAR T cells or bispecific antibody can be used as maintenance, can cure patients, but we have available options for patients when they relapse. And the optimal therapy is based on your needs. You need to discuss your options with your doctor. Say, why am I doing this? Can I do a different regimen? Because I think quality of life is very important. Being able to enjoy life is very important. So I think do not hesitate to ask for options, because as I showed you, based on the NCCN guidelines, there are many, many options for you when you relapse. So do not be afraid. Ask for options. And I think the most important thing in my mind is that when you have a relapse disease, try to get it right at the first relapse. Because when you start having multiple relapses, sometimes it's really hard to manage that. I think that's my last slide, Kylie, is it?
Yes, it is. And can we go back to the slide there? I love the optimal therapy is the one based on your needs.
Yes, sir.
Rafat, I remember you telling me that a long time ago, and I was very green to this world. And that was something that really stuck with me for a long time. And you displayed that in your slides and your talk today. The final one is we need to get it right at the first relapse. So as Dr. Abonour said, there are so many things going on, so many trials, so many new drugs, et cetera, coming out, that the outlook is better as a myeloma patient than it was even 10 years ago. So Rafat, thank you very much. That was a great talk.